Ladies and gentlemen, greetings and welcome to the 5th Annual Smart Africa Conference on Child Behavioral Health in Sub-Saharan Africa. My name is Proskovia Nabunya. I am a research assistant professor at the Brown School at Washington University in St. Louis. I'm also a co-director for ICHAD, one of our conference hosts. I will be your co-MC today with my colleague, Dr. Ann Mbwayo from the University of Nairobi. Dr. Ann is also the in-country co-investigator for the Smart Africa Center site in Kenya. This is our 5th conference. The last 4 conferences took place in Uganda. However, due to COVID-19, we are having this conference virtually. So thank you so much for joining us. This year's conference, under the theme of South to South collaboration, brings together the Smart Africa sites from Ghana, Kenya, Uganda, South Africa, and our colleagues from the US and around the globe to discuss ongoing projects related to scaling up evidence-based child mental health interventions, share lessons learned, and inform policies and programs in our partner countries. We are very grateful to our hosts and sponsors, specifically the Smart Africa Center, ICHAD, the Brown School, and Washington University in St. Louis, and our funders, the National Institute of Mental Health. Now I would like to invite my co-MC, Dr. Ann, to introduce herself and also take us through some of the housekeeping notes for the day. Dr. Ann.
Thank you very much, Dr. Prosi. I'm Dr. Ann from Kenya, as you've been told, and I'm going to take you through the housekeeping rules. So all participants will be muted in listen-only mode and cameras will be turned off. Please submit questions via question and answer box anytime during the presentation. If you have technical difficulties hearing or viewing the webinar, please note this in the Q&A as well. And you can also email lpia@wustl, as you can see, .edu. And there's also the YouTube channel, and you can see it's given there how you can move into it. Thank you.
Thank you, Dr. Ann. So our event is streaming live on YouTube. If you have any difficulties here, please, you can check our YouTube. Now, we would like to invite Dr. Fred to give his preliminary remarks. Dr. Fred is the professor and director of the Smart Africa Center, the founding director of ICHAD, and the lead principal investigator of the Smart Africa Scale-Up site in Uganda. Dr. Fred, the floor is yours.
Yeah, thank you so much, Dr. Proskovia Nabunya. Thank you so much, Dr. Ann Mbwayo. I want to welcome our Chancellor, Andrew Martin. We want to welcome our keynote for the day, Vikram Patel, and we also want to welcome all our colleagues. We call them our colleagues from the National Institutes of Health. As Dr. Proskovia Nabunya has indicated, I'm a professor at Washington University here in St. Louis, and I have the privilege of working with Dean Mary McKay, and I also have the same privilege of working with Dean Mary McKay on the same study that we are going to present today as my co-PI, and Kimberly Hogwood at NYU as co-PIs. In the next slide, which is the only slide where I'm going to give you really wordings, I want to take you through what the conference objectives are. We want to be able to organize this conference as a South-South collaboration in order for us to be able to provide a format. We want to be able to update our community stakeholders about our study findings from 5 years of research happening in the Global South, specifically in the Sub-Saharan African subcontinent. We also wanted to have a forum where we can share bidirectional exchange among researchers, both from the Global South and also from the Global North. But we are not going to stop there. We'll be able to hopefully accelerate scientific progress in this area through the publication. We have a special issue that is going to result out of this conference. So you are all welcome. Those are the objectives for the conference today. This conference would not have been possible without a dedicated committee of scholars, both from the Global South and the Global North. I won't mention their name here, but I think you can see their pictures. It took us almost a full year to put up this conference and to adjust from having it in person to conducting it virtually. I would also like to highlight our executive steering committee who have worked with us for the last 5 years. Waking up, anyone who has done global work will tell you it takes a village, but it also takes dedication. We've been waking up very early, 7 o'clock here in St. Louis, 8 o'clock Eastern time, 4, 5 o'clock, 8 p.m. in the in the Sub-Saharan African continent, depending on the time period. So this is the group that has steered the Smart Africa for the last 5 years. We would also love, in the next slide, to acknowledge our advisory boards in country. So we had advisory board members in Ghana, in South Africa, in Kenya, in Uganda, and we were able to really use them for them to inform our research and some of the findings that you are going to listen to today. In the next slide, what I really want to highlight are our NIMH team. I mean, these are the best program officials that you could have asked for. So we are extremely grateful to each one of them. So we started with, Dr. Beverly, Ish, Hori, Ashley, Anne, and so many others who have worked with us. But these officials here have woken up every day thinking about our study, and every day they have been there to guide us. So we are extremely grateful to our NIMH colleagues. In the next slide, what I want to show are the different teams that have really gotten this work to where it is. We had a long list of team members in Uganda. That's just a small number of the scale-up site in Uganda. We had colleagues in South Africa, Avin and Ingi. We are extremely grateful. Then we had colleagues in Kenya. We are going to show you in the next slide, where Kenya was our capacity building site. So we are very, very grateful. That site was led by Dr. Anna Mbwayo as the PI, and she worked with colleagues Manasi, Muthoni, and Teresia. Then we had a very strong team in Ghana, led by Richard, Emmanuel, Abdara, and then implemented by Kingsley and Peter. And in the next slide, really, I want to highlight our keynotes for the 2 days. We are extremely grateful that WHO is being represented, NIMH is being represented. We have our colleague who has worked with us for a long time, Vikram Patel is also here. And then we have someone from UNICEF who is also going to give some remarks. So for the next 2 days, you are going to be treated to a very, very full conference. It's as if you'll be in person. It is going to run from 8 o'clock to 11:30 Central Standard Time. We'll have panels, we'll have individual presentations, we'll have keynote remarks, and then we will also be, we'll also have poster presentations during those 2 days. So in the next day, the last day, we'll be able to summarize with Dean Mary reading us and be able to see what are the lessons that have come out of the field, but out of the presentations also. So as you can tell, this is really going to, it has not only taken a village for us to get where we are, but it's also going to take a village for us to come up with a final, product that will appear in our special issue, which we are looking forward to that, and we'll be sharing with you. So at this stage, I want to invite my dean and my co-PI on the Smart Africa study, and my co-director on the Smart Africa Center, which I direct, Dean Mary McKay.
Thank you, Dr. Fred. Thank you, Prosi, and thank you all. So let me wish you a good morning, a good evening. Welcome to this 5th annual conference. Some of you have been with us the entire journey. If you are new to us, this is an amazing community of scholars, community leaders, people that care greatly about the science of children's mental health. And so let me extend a very warm welcome to all of you. So my job is to, in a very small number of minutes, let you know what the Smart Africa Center is about. And I'm incredibly grateful that Beverly Pringle, who was our original program officer from the National Institute of Mental Health, but also that Director Joshua Gordon, Dr. Holly will be here representing our primary funding source for SMART Africa. So what's SMART about? It is an amazing transdisciplinary collaboration. It's a partnership with scholars, with community leaders, with people on the ground, young people and their family across a set of country contexts. Our partners are in Uganda, Kenya, Ghana, South Africa, as well as the US. And SMART Africa and our colleagues that are also funded similarly by the National Institute of Mental Health. Our goals for these centers are ambitious, to bring together these partnerships, to come up with new solutions that in our case address children's mental health issues, new evidence-based solutions that actually can be scaled in low and middle income countries. So an evidence-based practice that comes out of the best of science, but also is culturally and contextually relevant. It builds upon existing resources, strengths, is endorsed by respected leaders, and is tested rigorously. And so I'm incredibly grateful to those expanded teams across country contexts that are very serious about collaboration around developing best practices for children, but then also rigorously testing those practices. So SMART Africa has goals in terms of advancing science in children's mental health research, but it also has the kind of other foci around developing capacity, the next generation of child mental health services researchers, scale researchers, implementation sciences that are all focusing on children, their families, and their communities. And so in addition to SMART Africa activities, Dr. Fred and so many others here on the call have expanded our funded portfolio to really train intensely the next generation of child behavioral health scientists across low and middle income countries with a particular focus on Sub-Saharan Africa. And finally, SMART Africa Center has been charged by the NIMH to do something that very few scientists do, but our Chancellor will appreciate, which is to bring science to policymaking. As there is an increased focus on supporting children in low and middle income countries, stabilizing families, supporting communities, those policy moves, the legislation that is passed, the supports and the resources made available or not matter. And so that science informs that process across the continent is incredibly important to SMART Africa. So I'm going to have the privilege now of introducing the Chancellor of Washington University. And you can read about Andrew Martin and his really extraordinary academic career, both at Washington University. He did make a brief stop at University of Michigan. We are glad you're home, Chancellor Martin, in St. Louis and at Washington University. There's a couple of things that I want to say that are not in Chancellor Martin's bio that are incredibly important that I appreciate as a dean, and I know my colleagues at WashU particularly appreciate about you, Andrew. And that's a couple of things that you have really, since you've come, made sure that you put in front of somebody like myself as a scholar, the importance of rigorous science, scholarships at the highest level. And so what you have here is a team of scholars, both at WashU and around the globe, that National Institute of Mental Health has invested in heavily. So this is some of the most rigorous science, as well as an agenda that allows science to have many, many partners so that we can come up with new solutions. Many times SMART Africa talks about bi-directional learning. And so one of the purposes of the South to South Conference is that we learn from around the globe. And that could even inform, Chancellor, some of the things that you strive to achieve in our local community in St. Louis. And so we're incredibly grateful that you're here. We're incredibly grateful that right after you, Dr. Joshua Gordon is going to make some remarks, the director of the National Institute of Mental Health. And so we so appreciate your emphasis on academic distinction in local research, in US-based research, but also around the globe. Thank you, Chancellor, for being an incredible leader and for making some remarks to us today.
Well, thank you, Dean McKay, for your introduction and for your leadership here at Washington University, as well as your introduction to this conference. Good morning, everyone. Good evening, everyone. And thank you for joining us virtually for our annual conference on child behavioral health in Sub-Saharan Africa. I am thrilled to see so many policymakers, practitioners, community members, colleagues, NIH-funded trainees, and researchers from across the African continent and the US gathered together in one space to champion this important work. I'm also pleased that here at Washington University, we can use this event to provide a platform to discuss how together we can move the important work on child and adolescent mental health on the continent forward. Thanks especially to our colleagues and leaders at the Smart Africa Center and the International Center for Child Health and Development for organizing this event. Funded by the National Institutes of Health and led by outstanding faculty, specifically Doctors Fred Ssewamala, Proskovia Nobunya, and Ozge Sensoy Bahar, along with Mary McKay. ICHAD at the Smart Africa Center houses an expanded number of studies focused on developing, testing, and scaling culturally and contextually aligned solutions to critically burdensome childhood health and mental health challenges in Sub-Saharan Africa. I'm immensely grateful for their incredible work in these areas. And of course, I'm grateful to our featured speakers for being with us and sharing their wisdom and insights. Today's theme touches on the collaboration required to strengthen child and adolescent health in Sub-Saharan Africa. Here at WashU, we believe wholeheartedly that we cannot achieve progress in a vacuum. Indeed, it takes all of us rolling up our sleeves and working together across sectors to address the world's most pressing challenges, this being a paramount one. At Washington University, we are uniquely positioned to foster that kind of collaboration, particularly because so much of our global research runs across our entire university, where many in our schools and departments work together. In fact, just one example, ICHAD Smart Africa faculty are currently working with Sam Fox School of Design Visual Arts on a project to design artwork to address stigma associated with mental health in elementary schools. This collaboration also extends into the community and the many organizations represented here today. I'm extremely proud of the way so many of our research initiatives, especially this one, draw on the expertise and partnership of community and local stakeholders, foundations, research and funding organizations, and more. If you aren't already aware, here at WashU, we are host to a number of global research projects that span myriad issues around the world. Certainly our commitment to the continent of Africa is one of our significant enterprises, with more than 40 departments represented across WashU in our Africa initiative, engaging more than 120 faculty and more than 140 students in research activity. We also conduct research that benefits communities in India and Bangladesh, for example, along with research that benefits all of us as global citizens, from climate change to biodiversity, global health, and human rights. We already have a firm foundation for so much of this work, though we must continue to do more in order to discover real solutions to imminent and life-threatening problems. I'm thrilled that Washington University in St. Louis has become an anchor institution for global research, and that we have so many other organizations and institutions playing an equally significant role in partnership. Thank you once again for being with us to celebrate our shared accomplishments thus far as we look to the future with renewed resolve and energy. I wish you all a really terrific conference.
Thank you, Chancellor. It means a lot to us that you're here, made those remarks. We hope that in the background as you go on your day, you'll put on our YouTube channel and listen to some of the extraordinary talks. Thank you so much for being with us.
Thank you very much, Chancellor and Dean Mary. It's now my pleasure to invite Ivan, a fellow PI from South Africa in the Smart Africa. And Dr. Ivan is going to introduce Professor Vikram Patel, who has done a lot of work on the African continent. Dr. Ivan.
Thank you very much, Anne, for introducing me. It's a distinct honor and privilege to be associated with Smart Africa, especially Dr. Ssewamala and Dr. McKay. On a historical note, our relationship spans the better part of 20 years. I'm especially delighted and have the privilege to also introduce a colleague and a friend with whom I've had an association, long-standing association, and with a growing focus on child and adolescent mental health, a focus on key issues and future directions is especially timeless. Dr. Patel is the Pershing Square Professor of Global Health in the Blavatnik Institute's Department of Global Health and Social Medicine at Harvard Medical School. And he is an adjunct professor at the Public Health Foundation of India, honorary professor at the London School of Hygiene and Tropical Medicine, and is a co-founder of Sangat, an Indian NGO which won the MacArthur Foundation's International Prize for Creative and Effective Institutions in 2008, and the WHO Public Health Champion of India Award in 2016. He is a co-chair of the Lancet Commission on Reimagining India's Health System. I hand over to Dr. Patel.
Well, thank you so very much to the organizers of this conference for the great privilege of presenting in this opening session. Particular thanks to the PIs, but also to the wider community. So I have 15 minutes and I'm going to try and take you through a quick tour of what we know about developmental science in childhood and adolescence in particular, and how that might translate into scalable preventive interventions for children and adolescents. Let's begin long time ago historically. I'm sure many of you recognize this very grim and angry looking man here with a beard. He's actually the founding father of psychoanalysis and perhaps the founding father of psychiatry, Sigmund Freud, who first was one of his most important observations was the childhood origins of poor mental health. Whereas he actually did have a theoretical framework to explain those particular relationships, which we now have debunked. Here you can see on the slide the psychosexual stages that Freud championed. The fundamental observation that what happens to you in your childhood, in your earliest years of life, have profound long-term implications on your mental health and well-being in adulthood has stood the test of time. And indeed today, this is the most replicated and definitive risk factor for poor mental health in adult life. In fact, the CDC places great importance on adversities in childhood, what it calls toxic childhood environments because of adverse childhood experiences. And on this slide, you can see on the infographic here that there's a dose-response relationship. The more adversities you experience in childhood, the worse are your adult health outcomes. And when you look at adult health outcomes, you will see, of course, amongst the most common mental health problems in adulthood. But also you will see a number of other non-mental health related outcomes, so much so that preventing adverse childhood experiences, the CDC estimates in the US alone could avert as much as 21 million cases of depression every single year. Now, many of us are really accustomed to thinking of adversities in very extreme ways, such as the ones that are shown on this slide, a parent having a serious mental illness or a very significant traumatic event like a disaster or severe maltreatment. But in fact, the most common adversities are linked to poverty. And this is, of course, why children in parts of the world, such as in Sub-Saharan Africa or South Asia, are particularly vulnerable to experience these sorts of adversities that you can see right at the top of the list, just simple bog standard adversities associated with poverty of your family, but also other kinds of adversities, for example, such as marital conflict. These adversities are, of course, much more commonly experienced by children around the world. Additionally, in parts of the world, such as in Sub-Saharan Africa, our children also have to contend with a number of other adversities that have now been demonstrated to affect early life brain development and ultimately mental health across the life course, such as extreme forms of malnutrition that lead to stunting, a variety of infectious exposures, and of course, perhaps a worry that I have greatly in India, where I spend half the year, is enormous levels of environmental pollution, particularly air pollution. So Freud was right. What happens in the earliest years of your life have profound long-term implications to your mental health across your life course. And we now know through epidemiological literature that actually there is a very strong association between adversities in childhood across the range, including most importantly adversities associated with poverty and poor child development and mental health. What is the mechanism through which these associations are mediated? Clearly, it's not the psychoanalytical theories that I briefly touched on right at the beginning. Well, we now know a lot from neurodevelopment that helps us unpack the mechanisms. And a key point I want to start off by saying is that there are two very developmentally sensitive critical periods in life during childhood and adolescence. The first important critical period is during the first few years of life, from the time of conception, of course, but mostly after you're born for the first 2 or 3 years of life before you enter preschool. And this is a critical developmental period that you can see here, because this is the time of life when the brain is most plastic, that is to say, it is most responsive to environmental experiences. And that is a very important piece to keep in mind. The brain's neural networks are being shaped by environmental stimuli. That is why my colleagues in the Center for the Developing Child at Harvard describe neglect as having a double whammy impact on the developing brain through two different discrete mechanisms. The first is that there is a need for responsive parenting in order to build the necessary neural architecture of the brain. And when a child is neglected, particularly psychosocially, that key interaction that is needed to build the architecture is missing. And the second is that in very extreme circumstances of adversity, you have toxic stress, that is persistent stress with no relief, no escape, that leads to a chronic activation of the stress circuits, which in turn damages brain development. But there's a second developmental stage that is just as important, but we've only now come to realize is a very unique and quite a different developmental stage in the early life course, and that is during adolescence, extending all the way up into the early 20s, what we now refer to as emerging adults. If we had to look at this group together, young people or youth is another term that is widely used. This slide comes from the Global Burden of Disease data. And what it shows is the bulge that we now see in every society, the bulge that reflects the very high contribution of mental health problems and self-harm, which is the gray bar, the shorter bars, to the overall burden of disease in across the life course. This is what you can see on the x-axis. The highest relative burden is during the ages of 10 to 30. And of course, this reflects the fact that most mental health problems emerge, in fact, during adolescence and young adulthood. Now, what might be the reason for this? In fact, no, I should tell you something else. From COVID-19, we can also see as data emerge around the impact of the pandemic on mental health at the population level across different age groups. This is data from the US. You will see that the highest prevalence of self-reported mood and anxiety problems actually occurs in the youngest Americans between the ages of 18 and 30, where nearly 2/3 of young Americans reported significant symptoms of mood and anxiety conditions. So what is the mechanism? Well, these understandings are very new, I would say only in the last 10 years. And for those of you who want a really easy read on explaining these neurodevelopmental processes, I'd recommend this book, which in fact I found very handy. Coincidentally, it was published just when my son had entered adolescence, and I found this far more useful than any neuroscientific literature. In a potted way, really what this book tells us is that the primary and very unique developmental phase of adolescence, of course, there's still plasticity going on, but additionally, a very unique part of this, this phase of life is that the brain's maturational processes are happening in a differential way in different parts of the brain, so that the limbic cortex, which is deep inside the cerebrum, which mediates our raw emotions. This is the part of the cortex which is, the part that links us to our primate cousins, and mediates raw emotions like rage, anger, joy, and so on, matures soon around the period of puberty. But the part of the brain that's immediately behind our foreheads, the prefrontal cortex, which is associated with executive functions, abstract reasoning, judgment, and so on, matures actually between 5 to 8 years later. In other words, the brakes that make you stop before you act actually mature a good 5 to 8 years before the later than when the part of the brain that mediates your raw emotions, like the ones that make you want to take risks, to get rewards, to seek thrills. In other words, what this means is that adolescents and young people are biologically and indeed the evolutionary primed to behave impulsively, to seek rewards, because this offers very major advantages as we make the enormous leap from childhood, when we are totally dependent on our parents for every decision, into adulthood, when we are totally autonomous and indeed need to be taking decisions for people who we are caring for. So this is the risk-taking stage of life, when the young brain offers huge advantages in terms of learning and memory on the one hand, but also because this is a phase of life when we take a lot of risks, it also presents unique vulnerabilities. And of course, those vulnerabilities are linked to harms in the environment that you can see listed here. Life transitions, of course, very dramatic, and there's all kinds of disappointments that are likely to happen when you're making these enormous life transitions. And you can see some other examples, which I'm sure many of you will be familiar with. In other words, what developmental science clearly shows us is the mechanisms through which adversities in our environments in the early years of life that start from birth and extend all the way up into our early 20s are the critical targets for preventing mental health problems. We need to fix the prevention problem, not by trying to fix the individual, but trying to fix the environments that these individuals find themselves in. And actually, the environments that we are able to target are quite focused. For the first few years of life, these are the parental or home environments. From the school years of life, these are school and college environments. And of course, as young people begin to engage with their neighborhoods and their broader communities, there are community environments. In the disease control priorities work for the World Bank, we identified evidence-based interventions at each of these levels. At home, strong evidence on parenting interventions. In schools, both interventions targeting individuals in terms of teaching life skills, particularly to do with emotional regulation, but very importantly, promoting healthy social environments in schools. And of course, at the broader society, in the form of economic interventions for low-income families and challenging discrimination. Actually, I should have added challenging discrimination against young girls, which is a very important problem in many parts of the world, but also against minority groups. Let me just give you two quick examples of these interventions, and then I'll close out. Here is an example of parenting interventions. This is a systematic review led by Francis Aboud and Aisha Yousafzai, looking at parenting interventions to promote cognitive development, a critical attribute on the pathway to mental health. And you can see here these parenting interventions, all done in low and middle income countries, had a profound and large impact on healthy cognitive development in young children. So much so that today the World Bank really considers this a low-hanging fruit to promote child development through parenting. And in our program in Harvard with partners in University College London, we are using the curricula of these effective interventions to develop a curriculum that can be scaled up through our Empower initiative on digital platforms to train health workers anywhere in the world to work with parents to implement these parenting interventions, at the heart of which is the notion of responsive caregiving. And the second intervention is something I personally led and have been very passionate about in India, working in the poorest state of India, Bihar, where we designed an intervention to target the school environment for adolescents. I've highlighted here the key mechanism that we focused on, which is positive school climate. This is the schools that we worked in, and these are actually intervention activities in play. We published our primary endpoint results at the end of 1 year of the intervention in the Lancet and at the end of 2 years in PLOS Medicine. And what you can see here from the Lancet paper is the effect sizes of a lay counselor coordinated intervention for promoting school climate, which was a whole school intervention, and the impacts it had not just on school climate, but very importantly on key mediators and other secondary outcomes such as depressive symptoms and the frequency of violence. Importantly, for my colleagues in the US, these sorts of data are completely consistent with the National Academy of Medicine's report on fostering healthy emotional and mental development in children and young people. I've extracted this particular box from that report. And I want you, as you read this, you'll see some words that keep reoccurring: the focus on the community, the focus on diverse stakeholders, the need for leadership within organizations, and so on. And you can see that this kind of recommendation completely aligns with the environmental focus for interventions that I presented earlier. In closing then, what are the ingredients that we can take away from developmental science and experience on the ground for prevention? First, we must adopt a life course approach from conception to young adulthood, rather than the siloed approach that our field has traditionally taken, divvying up those young children, mid-course children in the middle years, early adolescence, and young people. There must be a life course approach for every individual. We must adopt an equity-focused population-based approach, recognizing that adversities are disproportionately distributed in the population, either due to factors to do with gender or due to economic arrangements. Third, we must adopt diverse community-based platforms for the delivery of these interventions that specifically target environmental or social determinants. And finally, we need active youth engagement, particularly for interventions targeting adolescents and young people, and leadership at all levels. Thank you very much.
Thank you very much, Dr. Patel. And I'm wondering if, I know your time is limited, but I'm wondering if there are any questions that have presented themselves. I can't quite see them.
There are no questions at the moment, Dr. Bana.
Okay. Well, then all it remains for me to say is, Vikram, thank you again for just summarizing a sort of range of reasons. I see Vincent has one. So Vincent, go ahead, please ask the question.
I don't think I can hear Vincent.
I think he can only put it in the chat.
Yeah.
So the question that Vincent asks, okay, there are a couple of them. Let me just read the first one. Can you give us a sense of which of the intervention elements you think is most important? And Dr. Abel, is there any difference in children raised by single parents and those raised by both parents?
Okay, let me take those two questions, Arvind. So the first one, for early child development, the mechanisms are still to be fully elucidated, but the mediators, which is the one step between the intervention and the mechanism, are largely to do with responsive parenting. It's active responsive parenting, which is the key mediator that all parenting interventions target. This is, of course, interventions in early childhood. And in adolescence, the key mechanism is trust. Trust, dignity that the individual feels in terms of their relationships with their peers in the school environment, but also the adults in the school environment. And that's really what school climate is. It's a fairly complex construct. I'd suggest you go to our papers and you will see that construct described and how it's measured, and you will recognize different kinds of variables that go into the concept of school climate. But really, at its heart, it's the degree of trust and also the degree of engagement that adolescents feel in terms of influencing the environments that they find themselves in.
Thanks, Vikram. Let me just
the single parent. You know, the literature is ambiguous on this. There is some literature that suggests that single parent families tend to have higher rates of mental health problems, but a lot of that is confounded by the social circumstances that are often associated with marital breakdown. And so one should be very careful before drawing any conclusions that this is due to the arrangements of being a single parent without taking into account the broader social determinants in which marital difficulties occur. But I will say one thing, that marital conflict is actually one of the most important predictors of poor mental health in children, as you will have seen in one of my slides during the presentation.
So there's a question that I have, Vikram, that's essentially sort of asking about what major challenges have you had to overcome in low resource settings? And why do you think it's important to address these barriers?
Well,
let me just ask the second question that goes quickly with that, is the issue around, this is from Manasi, to help address, do you think mental health interventions help address poverty in the long run? Any lessons from policy or practice?
Sure. Well, let me take the first question. You know, I think the biggest problem I have faced in this field is the fragmentation and the siloing of all the disciplines that are concerned with ultimately the same issue. So here we have a conference on child mental health. I don't know how many researchers who work in early child development are participating. How many researchers who work in neuroscience in relation to developmental science are participating? How many researchers who define themselves as working with social, environmental, and school health interventions for young people are participating? And so if you look at the bewildering number of disciplines that have emerged in the last 30 or 40 years, all of which focus on the brain in early childhood up into adolescence, and none of whom really actually work together in a cross-disciplinary way. This is, I think, the biggest challenge of all. And I would urge my colleagues to really reach out. For example, early child development, which I think is a profoundly important preventative intervention for mental health, is a big community, much bigger than child mental health. It has enormous resources backing it. And I would love to see much more conversation going on between those groups. And in terms of the Manasi's question, I believe it can. I believe mental health, you know, I'd alert you, Manasi, to look at the paper we had in Science in December last year, which is a review article looking at the mechanisms through which poverty and mental health, poor mental health are related, looking specifically at depression and anxiety. And a key message from that paper is that the mechanisms are bidirectional, and which of course means that addressing mental health problems can also act as a very important strategy to break the vicious cycle between poverty and poor mental health.
Great, thank you so much, Vikram. I'm not sure, I don't think we have any more questions, so it's for me to thank you very much for your contribution, and as usual, just really fantastic to hear the sort of directions we should take. I think they're sort of really great directions. So thanks a lot again.
Thank you very much.
And thank you so much, Dr. Patel, for that excellent presentation. And thank you so much, Dr. Bana, for moderating. Now it's my pleasure to welcome our NIMH program official, Dr. Holly Campbell-Rosen, who will give some remarks and also invite Dr. Joshua Gordon, the director for NIMH. Dr. Holly.
My apologies.